Hi, my name is Dr. Hillary Norton. I'm a board-certified rheumatologist and medical director at Inspire Santa Fe Medical Group. I hope you're ready to explore what's possible when choosing SAPHNELO, anifrolumab-fnia. SAPHNELO is indicated for adults with moderate to severe systemic lupus erythematosus, SLE, who are receiving standard therapy. SAPHNELO is not recommended for use in patients with severe active lupus nephritis or severe active central nervous system lupus. Please watch the complete video for additional important safety information, and please see the prescribing information, including patient information. Let's dive right into the clinical data from the SLE program, including results from the long-term extension or LTE safety study. The efficacy and safety of SAPHNELO were evaluated in 3 52-week, multi-center, randomized, double-blind, placebo-controlled studies. TULIP-1 and TULIP-2 were phase 3 studies, and MUSE was a phase 2b study. The primary endpoints for TULIP-2 and TULIP-1 were BICLA and SRI-4 response rates, respectively. In MUSE, the primary endpoint was a combined assessment of SRI-4 response rate and sustained reduction in oral steroid use. All studies included patients with moderate to severe active SLE who were receiving standard therapy. In the TULIP trials, standard therapy included either one or any combination of the following: antimalarials, immunosuppressants, non-steroidal anti-inflammatory drugs, and/or oral corticosteroids, or OCS. Patients continued to receive their existing SLE therapy at stable doses, except OCS, which were tapered per protocol. SAPHNELO was evaluated using both BICLA and SRI-4 across all pivotal studies, and reductions in disease activity were seen with both measurements. In MUSE, the primary endpoint, SRI-4 response rate and sustained reduction in OCS, favored SAPHNELO over placebo with statistical significance. In TULIP-1, the primary endpoint, SRI-4 response rate at week 52, was not statistically significant. In TULIP-1, BICLA response rate was a pre-specified secondary endpoint, but not formally tested, and results are descriptive only. In TULIP-2, the primary endpoint, BICLA response rate at week 52, favored SAPHNELO over placebo with statistical significance. In TULIP-2, the SRI-4 response rate was a pre-specified secondary endpoint but was not adjusted for multiplicity. Therefore, the results are descriptive only. Here's a look at SAPHNELO's impact across organ domains as measured by SLEDAI-2K at week 52 in a post-hoc pooled analysis of TULIP-1 and TULIP-2. SLEDAI-2K organ domain response was defined as a reduction in baseline SLEDAI-2K organ domain score. At baseline, the median SLEDAI-2K score was 10 in both groups, with an interquartile range of 8 to 13. In TULIP-2, a key secondary endpoint was the proportion of patients with OCS greater than or equal to 10 milligrams per day at baseline who achieved a tapered OCS dose of less than or equal to 7.5 milligrams per day at week 40 and maintained that dose through week 52. This endpoint was examined in the subgroup of patients with baseline OCS greater than or equal to 10 milligrams per day. As a reminder, at baseline, the mean OCS dosage for patients in the SAPHNELO group was 10.62 milligrams per day, with a standard deviation of 6.38, and 10.73 milligrams per day with a standard deviation of 7.63 in the placebo group. More patients in the SAPHNELO 300 milligram plus standard therapy group, approximately 52%, reduced OCS dosage than the placebo group, approximately 30% of patients, to less than or equal to 7.5 milligrams per day from weeks 8 to 40 and sustain the dose from weeks 40 to 52. In fact, 72% more patients on SAPHNELO achieved a sustained OCS dose reduction to less than or equal to 7.5 milligrams per day. Consistent trends were observed in TULIP-1, but the results were descriptive only. An additional key secondary endpoint of TULIP-2 was the annualized flare rate through week 52. A flare was defined as severe disease activity, bilag A, in one or more new organ systems, or moderate disease activity, bilag B, in two or more new organ systems compared with the previous visit. Treatment with SAPHNELO led to a 33% reduction of the annual flare rate versus placebo, with an annualized rate of 0.43 for SAPHNELO and 0.64 for the placebo group, respectively. This difference was not statistically significant following adjustment for multiple comparisons. In TULIP-1, the annualized flare rate was 0.60 for SAPHNELO plus standard therapy compared with 0.72 for standard therapy alone. Results are descriptive only. Shifting to safety, this table shows adverse reactions that occurred at greater than or equal to 2% incidence for SAPHNELO 300 mg administered by IV infusion every 4 weeks compared to placebo in 925 patients with moderate or severe SLE in the 52-week Phase 2 and Phase 3 controlled trials. Adverse reactions occurring in greater than or equal to 2% of patients enrolled in MUSE, TULIP-1, and TULIP-2 included upper respiratory tract infection, bronchitis, infusion-related reactions, herpes zoster, cough, respiratory tract infection, and hypersensitivity. The most common infusion-related reactions for SAPHNELO included headache, nausea, vomiting, fatigue, and dizziness. We will now review the LTE safety and tolerability study of patients from TULIP-1 and TULIP-2. The LTE study was a multi-center randomized, double-blind, placebo-controlled Phase 3 extension study to characterize the long-term safety and tolerability of anifrolumab. To the best of our knowledge, this 3-year study was the first long-term placebo-controlled extension trial ever performed in adult patients with SLE. To be eligible for inclusion in the TULIP LTE study, patients must have completed TULIP-1 or TULIP-2 through week 52, met all LTE eligibility criteria, and provided consent to join the LTE study. Patients who received SAPHNELO 300 mg in TULIP-1 or TULIP-2 or anifrolumab 150 mg in TULIP-1 received SAPHNELO 300 mg in the LTE study. Patients who received placebo were re-randomized 1-to-1 to receive either SAPHNELO 300 mg or placebo in the LTE. The LTE population had an approximately 4-to-1 ratio of patients receiving SAPHNELO 300 mg to patients receiving placebo. During the LTE study, adults received blinded intravenous SAPHNELO 300 mg or placebo every 4 weeks for up to 39 doses, alongside standard of care treatment administered at the investigator's judgment. The LTE study was primarily designed to evaluate and characterize the long-term safety and tolerability of treatment with SAPHNELO 300 mg every 4 weeks. The LTE reflects real-world clinical practice by allowing investigators to add or change background standard care treatment, including immunosuppressants and OCS. However, use of cyclophosphamide, other biologic drugs, IV immunoglobulin, or IV OCS was not permitted. Patients received 1 year of treatment in the initial TULIP study, followed by treatment in the LTE from years 2 through 4. There was an 8-week safety follow-up period. The primary objective of this study was to evaluate long-term safety and tolerability of SAPHNELO 300 mg in these patients. Exploratory outcomes included SLEDAI-2K, Physician Global Assessment, OCS use, and the SLICC Damage Index score. Flare incidence and severity were also assessed. Limitations of the LTE safety study include that it was not powered for statistical comparison of safety between groups, and events with longer latency periods would not be captured. There was a potential selection bias, as only patients completing a TULIP study and thus potentially doing well were eligible. There was no imputation for patients who discontinued or received additional immunosuppressants. Efficacy data could be biased based on patient withdrawals related to SLE flares. Now let's take a look at the treatment allocations during the transitions from the 1-year predecessor TULIP trials to the LTE trial. Of the 809 patients randomized and treated in either TULIP-1 or TULIP-2, 639 completed treatment in the year-long TULIP studies. 547 of these patients enrolled in the LTE. 257 continued SAPHNELO 300 mg and 67 switched from anifrolumab 150 mg during TULIP-1 to SAPHNELO 300 mg in the LTE. The 223 patients who had received placebo in TULIP-1 or TULIP-2 were re-randomized to SAPHNELO 300 mg or placebo in the LTE. Of 257 patients who had been receiving SAPHNELO 300 mg throughout, 69% completed the 3-year extension study, compared with 48% of the 112 patients who had been receiving placebo throughout. For the primary safety analysis, the main comparison during the 3-year LTE study was between the 257 patients from the TULIP trials who continued to receive SAPHNELO 300 mg in the LTE study and the 112 patients from the TULIP trials that continued to receive placebo in the LTE study. In this table, you can see the safety results for the primary comparison group in the LTE study for years 2 to 4. Because treatment exposure in the SAPHNELO group was 683.5 patient years compared with 250.3 patient years in the placebo group, the rates of adverse events were assessed using exposure-adjusted incidence rates, or EAIRs, per 100 patient years. The exposure-adjusted incidence rates of any adverse event were 33.1 in the SAPHNELO group compared with 37.6 in the placebo group. In the LTE, exposure-adjusted incidence rates of serious adverse events, including events with the outcome of death, were 8.5 for SAPHNELO 300 mg and 11.2 for placebo. And the most frequently reported types of serious adverse events, in which data is not shown in this table, were in the infections and infestation organ system, with 4.3 for SAPHNELO 300 mg and 4.7 for placebo. Looking now at the adverse events of special interest, exposure-adjusted incidence rates of non-opportunistic serious infections during the LTE were 3.7 for SAPHNELO 300 mg and 3.6 for placebo. Rates of herpes zoster were 3.4 in the SAPHNELO group and 2.8 in the placebo group. All patients were screened for tuberculosis at study entry. All patients with indeterminate tuberculosis tests at screening were followed up throughout the study, and any identified latent tuberculosis was treated with prophylaxis. There were no cases of active tuberculosis reported during the LTE study. Exposure-adjusted rates of latent tuberculosis defined by a positive interferon gamma release assay was higher in the LTE SAPHNELO 300 mg group than in the LTE placebo group. Rates of influenza were 2.2 in the SAPHNELO group and 0.8 in the placebo group. The most common adverse events in the LTE were nasopharyngitis, urinary tract infection, and upper respiratory tract infection. The overall safety profile of SAPHNELO in the TULIP LTE was consistent with that previously reported in the pivotal studies. MUSE, TULIP-1, and TULIP-2 were the most common adverse drug reactions. Incidents greater than or equal to 5% were nasopharyngitis, upper respiratory tract infections, bronchitis, infusion-related reactions, herpes zoster, and cough. No new safety findings were observed in the LTE study. Here you can see the alternative event rates per 100 patient years of herpes zoster by year in the combined SAPHNELO 300 mg group and the all placebo group. A total of 48 patients had herpes zoster during the LTE period on SAPHNELO, of which 5 discontinued treatment due to herpes zoster. One patient in the combined placebo group received herpes zoster vaccination before treatment. During this study, herpes zoster vaccines were administered to 5 patients. Alternative event rates are based on time at risk instead of total exposure time, defined as time from start of the period to the date of first event, death, withdrawal of consent, or end of period, whatever comes first. Now let's switch gears and discuss exploratory efficacy, although it must be emphasized that the primary goal of this extension study was to evaluate safety and tolerability. Efficacy outcomes were exploratory and were assessed in groups of patients who did not change treatments over the 4 years of the TULIP plus LTE period, the combined SAPHNELO 300 mg group, and the combined placebo group. All exploratory outcomes are descriptive only. The key difference between these combined groups and the LTE SAPHNELO 300 mg and LTE placebo group was the time frame analyzed. The combined groups include data from years 1 to 4, TULIP trials plus LTE period, whereas the LTE period was from years 2 to 4. The proportions of patients stratified by mean OCS dose were evaluated by study year, with study year 1 on the left and study year 4 on the far right. Each histogram pair contains SAPHNELO-treated patients on the left and placebo-treated patients on the right. The legend displays the 4 dose ranges. The results of this analysis are descriptive only. The darkest shaded sections of the stacked bars represent the highest OCS dose range, with increasingly lighter shades indicating lower OCS dose ranges. The proportion of patients receiving mean OCS doses greater than 7.5 mg per day was lower in the combined SAPHNELO 300 mg group compared with combined placebo per year of the 4-year TULIP and LTE period. In year 4, approximately 90% of patients in the combined SAPHNELO 300 mg group were taking 7.5 mg or less a day of OCS, compared with 71% of patients in the combined placebo group. 36.4% of patients in the combined SAPHNELO 300 mg group were OCS-free at year 4, compared with 26.8% in the combined placebo group. Let's further review the data from the LTE study at year 4 in patients receiving SAPHNELO 300 mg and OCS. As we previously discussed, at year 4, approximately 90% of patients in the SAPHNELO 300 mg group were taking 7.5 mg or less a day of OCS, compared with 71% of patients in the placebo group. 36% of patients eliminated steroids. 74% of SAPHNELO patients were on 0 mg per day or 0 to 5 mg per day of steroids, compared with 64% of patients in the placebo group. During the TULIP trials and the LTE, cumulative OCS dose was lower among patients in the combined SAPHNELO 300 mg group compared with the combined placebo group. There was no forced OCS taper in the LTE study. Investigators were able to add or change background standard treatment, including immunosuppressants and OCS. At each of the 4 years during the TULIP and LTE periods, cumulative OCS dose, standardized AUC, was lower in the combined SAPHNELO 300 mg group compared with the combined placebo group. Flares were also assessed in this LTE safety study as an exploratory endpoint using the modified Selena Flare Index, which includes SLEDAI-2K, and results presented are descriptive only. Over 4 years, 96% of patients on SAPHNELO had 0 severe flares versus 91% of patients on standard therapy alone. Here we have the mean SLEDAI-2K score and mean OCS dose for SAPHNELO plus standard therapy and for standard therapy alone by year. Solid lines in this figure, corresponding to the y-axis on the left, demonstrate the mean SLEDAI-2K scores over time during the study. Patients in the combined SAPHNELO 300 mg group had a mean SLEDAI-2K score of 11.4 at TULIP baseline and 5.1 at week 52, compared with the 11.3 at TULIP baseline and 6.0 at week 52 for the combined placebo group. Patients treated with SAPHNELO 300 mg had greater mean improvement in SLEDAI-2K at week 52, with a corresponding reduction in OCS use, compared to patients on standard therapy alone. The reduction in mean SLEDAI-2K score was observed in parallel with reduction of the mean OCS dose. Now that we've reviewed the LTE study data, let's summarize some takeaways. To our knowledge, the TULIP LTE is the longest placebo-controlled trial of a biologic in SLE. The overall safety profile of SAPHNELO spanning across 4 years is consistent with that previously reported in the MUSE, TULIP-1, and TULIP-2 studies. In addition, a reduction in mean SLEDAI-2K score along with a reduction in mean OCS dose was observed. The proportion of patients receiving mean OCS doses less than or equal to 7.5 milligrams per day was higher in the combined SAPHNELO 300 milligram group compared with the combined placebo group over the 4 years, spanning the TULIP and extension periods. Next, let's review additional important safety information about SAPHNELO.
Important safety information. Contraindication. SAPHNELO is contraindicated in patients with a known history of anaphylaxis. Warnings and precautions. Serious infections. Serious and sometimes fatal infections have occurred in patients receiving immunosuppressive agents, including SAPHNELO. SAPHNELO increases the risk of respiratory infections and herpes zoster. Use caution in patients with severe or chronic infections. Avoid initiating treatment during an active infection, and consider interrupting therapy in patients who develop a new infection during treatment. Hypersensitivity reaction, including anaphylaxis. Serious hypersensitivity reactions, including anaphylaxis, have been reported following SAPHNELO administration. Events of angioedema have also been reported. Other hypersensitivity reactions and infusion-related reactions have occurred following administration of SAPHNELO. SAPHNELO should be administered by healthcare providers prepared to manage hypersensitivity reactions, including anaphylaxis and infusion-related reactions if they occur. Immediately interrupt administration and initiate appropriate therapy if a serious infusion-related or hypersensitivity reaction, for example, anaphylaxis, occurs. Malignancy. There is an increased risk of malignancies with the use of immunosuppressants. The impact of SAPHNELO on the potential development of malignancies is not known. Immunization. Avoid the use of live or live-attenuated vaccines in patients treated with SAPHNELO. Use with biologic therapies. SAPHNELO is not recommended for use in combination with other biologic therapies, including B-cell targeted therapies. Adverse reactions. The most common adverse reactions, incidence greater than or equal to 5%, are nasopharyngitis, upper respiratory tract infections, bronchitis, infusion-related reactions, herpes zoster, and cough. In the controlled clinical trials, the incidence of infusion-related reactions was 9.4% in patients while on treatment with SAPHNELO and 7.1% in patients on placebo. Infusion-related reactions were mild to moderate in intensity. The most common symptoms were headache, nausea, vomiting, fatigue, and dizziness. Use in specific populations. Pregnancy. A pregnancy exposure registry monitors pregnancy outcomes in women exposed to SAPHNELO during pregnancy. For more information about the registry, or to report a pregnancy while on SAPHNELO, contact AstraZeneca at 1-877-693-9268. There are insufficient data on the use of SAPHNELO in pregnant women to establish whether there is drug-associated risk for major birth defects or miscarriage. Advise female patients to inform their healthcare provider if they intend to become pregnant during therapy, suspect they are pregnant, or become pregnant while receiving SAPHNELO. Lactation. No data are available regarding the presence of SAPHNELO in human milk, the effects on the breastfed child, or the effects on milk production. Pediatric use. The safety and efficacy of SAPHNELO in pediatric patients less than 18 years of age has not been established. Please see full prescribing information, including patient information, at www.saphnelo.com/HCP.
Thank you for joining me. I hope you enjoyed this in-depth look at the clinical data from the SLE program, including results from the LTE safety and tolerability study.